discussion. And I'd like to invite Professor Abul Fazl. Sir, Professor Abul Fazl साहब, sir, हैं available हैं कि नहीं?
I've got a question, Maz.
Yes.
While Abu Fazal is coming, just a quick question. I think if you are leaving up to 300 centimeter of bowel, small bowel, why do you need to measure the rest of the bowel when you are, you said you've started measuring it now, the whole bowel, and then make sure 55% of it is bypassed. But if you are leaving 300 centimeters for absorption, why are you worried about measuring the whole of it?
Actually, what happened, I was getting very good results with 300 centimeters. There was one of surgeon in India. He's doing a lot of SASI. His name is Amar. I discussed with him, and he said, like there are few patients who have lost only 30, 40 kg, and after that they're not losing. And mostly after redo procedure. Obviously, as we have discussed many times, that your primary procedure is the best procedure in which you gain maximum amount of your weight. In redo sometime after sleep, if you do even MGB or UNY or even SADI, people sometimes they got stuck and they don't lose much. So he told me what he's doing now. He said he's calculating wall ball and from total wall, he just bypass almost 45%. 55% he leave that. I have done that in 7, 8 cases, and they are doing, I think, excellent. Still, we need to find out what is the reason and how they are losing more. But ideally, what I think 300, I think that is quite handsome amount, and that is sufficient.
Right.
But we need to have more results and more data available.
Okay, one more question that if you got, because I think SASI, I still believe it's a good operation for a second procedure in patients who've had a previous sleeve, right? So if you got a patient who is at a sleeve and has got reflux with GERD, as well as has regained weight, what procedure would you offer them?
Ruin why? Somebody who have got GERD and he had sleeve, I'll offer him Ruin why.
And do you get, what about the weight loss with that? Because my experience is that even if it's converted to Roux-en-Y after sleeve, weight loss is not as brilliant.
So then we have to increase the length of the curtain. More than 100, 125, and then 100, almost 225, 30. We need to do that. But what I have done in only 2 patients, those who have got a reflux, I just stitched the hiatus. They were small hiatus hernia, and then I did SASI in them. They did excellent. And 2 of my patients, they had reflux after sleep, and I didn't do Roux-en-Y. I did SASI, and their reflux have gone. I don't know. Still,
because there is a theory that one of the problem with the reason people get reflux is because of the pylorus.
Yeah.
Because it's a high pressure. So if you do a SASI, basically what you've done is you've taken away that high pressure and easy drainage. I don't know. I haven't never tried it, but would that help? I don't know. That's what
it helped. 2 of my patients, I did SASI. And that was also in my mind as you are this converting high pressure of sleeve into low pressure by opening the pylorus and anastomosing this one jejunum over there. So maybe that is the reason that reflux has gone. Still, we need to have some more data available.
Excellent presentation. We'd love to see the long-term results beyond 2 years as well. But fantastic result. Thank you very much. And nicely described the operation, the way you did it. Beautiful.
Thank you, sir.
Dr. Maz, I have a comment. First of all, Assalamu alaikum. And Saramir Khan, Assalamu alaikum, and Dr. Ghulam Siddiq, and everyone who is here hearing me. Dr. Maz, really excellent presentation. Excellent. And I appreciate your surgical skills. That was amazing. I have started SASI since 2016. And because I have faced some issues that must I share my experience. When I have started SASI at that time, my common channel was 250. Then I increased till 300. Again, I faced so more weight loss in these patients. So I was worried about this. So wait, as one of my case, I revised due to weight loss, more weight loss. And again, I so cut this this loop, and then this will be that was wide sleeve, and also she weight gain. So now they have started. They have changed some this SASI. Also, they started this jejunal bypass, not ileal bypass. In selected cases, if patient is low BMI mean between 30 to 40 with diabetes, and your target is only metabolic, not weight loss. Weight loss also, but with the target is diabetes below 40. So don't go for ileocecal, just bypass from Tritt's ligament 150 to 180, like MGB. And I have started this and excellent results, because if we will save only 300 centimeter, maybe we are bypassing 4 meter, 5 meter more. So then patient will lose more weight, because this is strong procedure. This is not simple procedure. This is malabsorptive procedure, because I have faced these issues. And first, when I have started this SASI, I have used 60 complete. And again, now I decreased this. Now 3 centimeter I prefer. This enterojejunostomy or that enteroileostomy, 3 to 4 centimeter. So then it's good result. So now I am also discounting from just like mini gastric bypass, but Tritt's ligament, maximum 200 centimeter and bypass. I never, now not going to till at the end, and also this common channel, just deal like this. This is also, this has been published in obesity, this article, and they name it like, this is not Saji, so just like, this is not Sasi, this is jejunal bypass. But overall, this, when we, as Professor Amir Khan so commented, so if we see, so this, when we add this loop, then we will change into low pressure. And also till this time, when we will go for second surgery for weight regain, until I did as Maz mentioned, so in GERD cases, also excellent result. No issue, no problem. Because personally, this is my personal experience. And also I have discussed with Tariq Mehdi, who is also one of the pioneer of SASI, and he's in UAE in Sharjah. Also now he's doing this SASI in case of GERD after a sleeve gastrectomy, and there is no issue.
Imran,
Sir,
did you experience, and also for Maaz, any significant malabsorption in these patients?
yes, sir. I experienced.
I have also seen, sir. Yes, one patient I told you, he was saying he was 140 kg and he came down to 75 kg in almost 11 months. And he said he is unable to eat much, and he's having some reflux also, and he was having malabsorptive issues. So I immediately reversed SASI. So that's why I've increased the distance now. Either I go to 350 or I count from there, and I just at 45% of the gut I anastomose. As Imran is saying, maybe it's like 3 meters.
Sir, in my opinion, so this is a strong procedure, because I have faced this, and this is not just because, just you can imagine, we have a sleeve with a bypass. So this is strong surgery. No doubt this is easy to do. No doubt this is useful. This is reversible. This is low pressure, much better than a sleeve gastrectomy. This is my opinion. So I cannot challenge, because this is personal, my opinion. So, but overall, if we see, definitely, because you have access to duodenum, you have, because in mini gastric, I have, so my main 60-70% is OAGB. But again, so if we see SASI, so now really I am also convincing for SASI. So you have access to duodenum. That's very important. If after surgery patient, and also you have a remnant inside in mini gastric bypass. In mini gastric bypass, you have two sleeve. There is more chance of bleeding. So just you have like, you can see two sleeve stapler lines there. So one is for remnant, other is for your gastric pouch. So you face, maybe you will face more complications. But if you do wide sleeve, because what is the SASI? So SASI is not tight sleeve. SASI is not restrictive procedure. SASI is pure, I can ask, this is a more dominant male absorptive procedure. So must be this sleeve must be on 40F, not on 36, because our target is male absorption. This gastric tube is just like a tube, straight tube, and then you go to ileum or jejunum. It will take time to mature this procedure, but still, yes, good results, excellent, much better than Sadi, easier than Sadi. I did Sadi many times, very difficult really. When you will do this jejunostomy or duodenal, very difficult, especially that area when you do duodenectomy and also anastomosis. Always, if you did loop, always kink there, because there is no space and there is more chance of ischemia at that area. And I have faced this in Sadi. If we compare with Sadi, Sasi is much better. And in Sasi, one thing that is the most important, low pressure. So because this is most important, there is less chance of leak in this procedure. But be careful, selection of the patient is very important. If patient target is only diabetes, so then we must go from Tritt's ligament. No need to go iliac also. 150 is okay, 180 is okay. So in 150, 180 from Tritt's ligament, it is sufficient. And then just you will boss this. This will be antrojejunostomy. So 3-4 centimeter, and excellent. You will achieve your target.
There's one question. There's one question from the attendee. He's saying he had SASI procedure, and my weight is gaining. He's saying he's gaining his weight again. He hasn't
so maybe
mentioned.
he started to eat sweets. So be careful. The surgery, that's my if he's hearing my humble request to my patients, and always I discuss with my patients, surgery is 30%. So 70% is post-op lifestyle change. If you will not change your lifestyle, you will start to eat sweets. So definitely you will gain weight, because this small bowel will accommodate and absorption will increase. So
the thing is that if you see that is the fate of all bariatric procedures, that any procedure will fail if a patient do not change their lifestyle. And
definitely.
That was the argument used, that when you do the first operation, always keep in mind that you might have to go back and to do something more later on. And I think how bariatric surgery is evolved. There isn't, human body is a fantastic organ. We would not be able to operate if it didn't overcome the problems we create.
Yes, sir. I agree with you, sir. Absolutely.
I always tell my patients, you have to change your lifestyle, because if you don't change your lifestyle, not even a single procedure can help you. Definitely, whatever procedure you do, you need to do something. Even bypass, as we had gone to Brno in Belgium, out of 13, 14 procedures, 7 were those patients who had gone Roux-en-Y a few years back. And he was reversing all that, either distalization or putting a banded bypass or reshaping that pouch. So any procedure, you have to be with that. You have not changed your lifestyle. We have forcibly changed your lifestyle with surgery, and you have to adapt to that. You have to consider mostly sweet eaters. Mostly those who are taking a lot of sweets, they gain weight again almost.
Yeah.
And I think the important thing also is that the patients need to remember that the second operation weight loss is not as good as the first one.
Yeah.
It never is, no matter how drastic and what you do to them. I think the lucky patients are the ones who get very bad dumping, so they can never become sweet eaters again.
Welcome, Dr. Umar. He is with us. And
Assalamu alaikum, everybody. Thank you very much for inviting me. Sorry, I was busy in the theater. so I wasn't able to connect early. I believe it was a wonderful presentation from all our dear colleagues. So SASI, what we are discussing is like a wonderful procedure. It seems to be like a wonderful procedure, and I believe you must have got very good results. So one impressive thing about SASI, which I have gathered from your discussion, is the that reflux is gone in those two patients in which you have converted sleeve into SASI. But my question is, once you have done standard sleeve, then wasn't it difficult to convert it into SASI with 3 or 4 centimeter from gastroduodenal junction?
No, it's not difficult. It's very easy. You just have to, we can just pass that staple line. You can go above or below, and it's easy. It's not difficult. You can do that. Now, normally we take 2-3 centimeter, but SASI you have to take almost 6 centimeter from the pylorus. Then you attach. So that is not an issue. What I have seen, if you leave that 6 centimeter area, then it works really well. If you are more toward pylorus, patient can have some reflux and some vomiting.
So, Dr. Umar Javed, Assalamu alaikum, first of all.
Welcome, Irman. Hope you are
Yeah,
well.
thank you.
You are looking, mashallah, nice.
Thanks a lot, sir. So regarding this SASI after reflux, after sleeve gastrectomy, we must rule out any kink of this or any functional obstruction of the sleeve at incisor angularis. If there is no issue, this is very important point. First of all, we must rule out that. So if there is any issue and also kink there, if only pylorus is cause of this reflux, that is natural due to high pressure, then you can add this loop and you will take the result. If there is also some kink above, so then you must go for Roux-en-Y, no doubt, because you will not achieve one thing. Another thing, if you see, because sometime when we will face this GERD after sleeve gastrectomy, there is migration of this sleeve inside. Again, we cannot do only SASI for this patient. So the reason is another, we must solve that because it depends on patient to patient. Patient selection is very important. So the cause of this GERD after sleeve gastrectomy, what is the cause? Is only this migration. So first of all, we must solve that issue. Then we can go ahead. Is there kink in this gastric tube or this sleeve? So then, yes, personally, I did some cases GERD, but yes, first of all, I have ruled out these things. Then I go for this loop for ileum or jejunum because my case weight was low, BMI was at that time low. I prefer 150 only. I think 150, 120 from jejunum at that time that I remember because the target was only reflux. Patient already has lost weight and there was no need to more excess weight loss. As I remember, I did 120, just my target was low pressure. And so solved. This there was no issue after that. So this point is very important. So after that, we must see what is the cause of GERD. Overall, till this time, there is no study. We have no data. This is for my viewers, for my juniors. So because we must follow the standard gold standard is Roux-en-Y. If till I am doing OAGB, I did many cases OAGB after reflux in selected cases. But again, this is not gold standard. If we will follow gold standard, yes. If patient is suffering GERD after sleeve, we must go for Roux-en-Y gastric bypass.
Thank you, Imran. I'm also impressed with your metabolic component of SASI as well. This one was new for me. So hopefully I will try, inshallah, in future.
Sir, you must do. SASI is very friendly, really, also for doctor and also for the patients. Because after sleeve gastrectomy, the main issue is restriction. So when you will do wide sleeve, because in SASI, there is no need to tight sleeve with 36. No, just with 40. And also still, just you are kissing this bougie, no need to tight this. And when you will do a straight this gastric tube, and when I do this SASI, I go just with right hand stapler. till I see Mars also got little antrum. I also leave that antrum. Completely I have antrum. Completely I have antrum. Just a straight, that is sufficient. And then we will do this. It depends on your case. If high BMI, then 300 you must save for the patient, 300 common channel, and it's okay. If patient is low BMI, then must go from Tritz ligament. 150, 180 is sufficient, and this loop will be sufficient. Anastomosis, in my experience, 3 to 4 centimeters. If we will do more, then again it creates issue, because then you will see, so this is large size, and also there is chance of dumping as well as, so patient will lose more weight. Because yes, again, one thing that I must ask, I did many times in these cases barium study to see my work. So till in 6 centimeter, you can't believe, also dye was in duodenum. This is not like this dye will go completely to ileum. No. I did many times till with thick barium, with different studies. So for myself, I want to see how it is working. Yes, also we have that pathway. But if this anastomosis will be wide, definite, so food will go more here and less. But what is our target? 50-50. So then this because the main target is metabolic. So when this undigested food particle will go terminal ileum, and you know better than me, then GLP-1 and that touching of this undigested food to L cell of terminal ileum and rise of GLP-1 and impact of GLP-1 to beta cell and other so metabolic. Amazing. It's good surgery. And
There's one question, Imran. People are
Yes.
asking from the panelist, somebody who had undergone sleeve gastrectomy, and she was almost 100 and she was 95 kg. She came back to 60 kg. And after 2 years, she's gaining her weight, and now she's 83. And she's doing her diet. She's taking some medication also, doing walk also. She doesn't have any other metabolic issues, but she's like very thin because of her weight, and she wants some redo metabolic procedure. At this weight, like 87 kg, what procedure would you like to opt for her?
Dr. Mas, first of all, because you have mentioned there is no comorbidity or any issue in this patient, again, I suggest the patient to go for this lifestyle change. For
All she has done, she said.
Then first of all, you must see, you must check. So because really it is working. If she follow all these instructions, she can lose weight. But if she cannot lose weight, and I don't know, what is the age of the patient?
47.
47. So you can check again, you can do a barium study and you can see the gastric pouch, dilated, not dilated. And I don't know, but it's a little difficult to decide. But I will not prefer surgery in this case. I must be honest. I will convince her to follow lifestyle change and conservative therapy. I will not go ahead for surgery in this case. With 87 kg, I prefer to go for lifestyle change. This is my preference.
Well, Mas,
Yes,
can
Umar.
I add something?
Yes.
Yeah, I have tried proximal bypass, proximal jejunal. So a patient usually with low BMI, they tend to lose 10 to 15 kg of their weight with exercise. And if we bypass about 250 centimeters, so after sleeve, they tend to lose about 15 kg of their weight. So in this patient, if otherwise she's fine, then we can offer her a proximal jejunal bypass. But personally, I agree with Imran that it's more of a lifestyle change and exercise and diet, which will help her.
Okay, that's great.
And at the end, Mahathir, at the end, in such a case, because I also face, because in Dubai, most of the patients, they never follow. This is reality, lifestyle change. We are asking, we are talking everything, but again, they start to eat, especially sweets and weight gain. Yes, I am for. Then you can't believe I am following weight gain in mgb. I am following here. This is because our follow-up is very strict. I follow all of my cases. So yes, I have case weight gain after mgb. So one of the issue, if such a case, and you just now we can imagine, yes, you have decided to do surgery, definite, this ileal bypass will be excellent. But in this case, this is redo. This is not primary surgery, go aggressive. So this is not like initial surgery. Just save 300, 350 in this 87th. I prefer 350 common channel and ileal bypass. I will not go for jejunal bypass in this case because this case is redo. And in such a case, so we must go little aggressive because yes, if a case initial surgery with this weight and with diabetes, then I will prefer jejunal bypass, not ileal bypass. When 150 is okay. But this case, yes, I prefer to measure total this bowel length and I bypass. I will be 40-60. 40 will be my BP limb, 60 will be common channel in this case.
Thank you, sir.
Can I ask a question from the prominence of SASI? I can understand the place for SASI in a redo operation, someone who's had a sleeve, and then if you want to offer them a second procedure, especially with the super obese. But why would you select, and what type of patients would you just select or offer them SASI rather than doing primary, either sleeve or a primary bypass with a, you can do a signal anastomosis or Roux-en-Y, whichever, when the results are equally as good if you look at the literature as far as the remission of diabetes is concerned and the comorbidity is concerned as a primary operation.
Thank you, sir.
Maz, you will answer, I can talk. So, sir, Amir Khan,
when I select, suppose somebody who comes for me as a redo procedure, what I select,
I meant primary procedure. Sorry, Maz, I meant primary procedure.
Yeah. As a primary procedure, when I do SASI, mostly I consider somebody who have got uncontrolled diabetes. Only for those I select, okay, they should go for SASI. But a lot of people, some people they are insisting when they heard about SASI, I want to go for SASI. I said, no, you are not suitable for that. I've got a patient, she was only 100 kg, and she said, I want SASI procedure. As I've seen, SASI is very good, and she somehow when she SASI, I just told her, hey, SASI, if I just do sleep for you, that is sufficient. And in spite of all that, she insisted me, and I had to do SASI for her. I did SASI with more than 350 this common channel, and what she lost her weight. She came to 60 and 65, but she's saying now I am getting some weakness. I've got some like wasting, and I got her levels done. They were slightly low iron, but the rest of things were okay. And I said, okay, we're going to reverse that. So SASI, it has got severe effects. Before that, as we haven't done much, people were saying there were no malabsorption. In every malabsorptive procedure, there is malabsorption. So one should learn that. There is not even a single procedure. If you do bypass, you think that you won't have malabsorption. If you are touching ball over there, you will have malabsorption. You have to live with that. You have to take your vitamins, minerals, everything. And so that is the message that you have to be aware of.
The reason I asked that question was, Mas, because I don't want us to give a message that people who do not have a very strong team, especially dietitian and your chemical pathologists, those involved with you, to go ahead and just start doing SASI in the centers. You need a very strong team to look after these patients. So I would suggest that for majority of us, probably stick to the straightforward, well-recognized procedures and keep SASI for the centers which are experienced or which have got a proper team to look after these patients, because they can be very difficult when they start developing malabsorptive problems.
Yes, well said. You have to, you are a beginner, we cannot advise everybody to go for malabsorptive procedures like MGB, even UNY and SASI. Go for simpler one. Sleeve is very good. Very good procedure in safe hands. If you do it nicely, you get extraordinary results.
Can I ask
Sir,
a question from the panel
sir, I
here?
have one,
Talked about
sir, I have
patient
one comment.
selection quite a bit. And Assalamu alaikum, Tahir.
Welcome back, Dr. Tahir.
Walaikum Assalam. How are you?
I
So
think
good to see you.
great, nice seeing you. Just a question from the panelist here. We know that we talk about lifestyle change, which is the ultimate goal of, or to get the best result from it. If a patient is in front of you who is a heavy smoker, and we know smoking does cause problem with all the operations, especially with the sleeve or even with the bypasses with the stomach ulcerations, would you operate on a patient or first ask them to test-wise to stop the smoking and prove they can stop it before you proceed on with surgical intervention? It's open to the panel. Anyone can take it.
So I actually, my routine is I always ask them about their smoking habits. And as a routine, I enroll them into a smoking cessation program. And I make sure that they have stopped smoking. Before coming to Pakistan, I would do it objectively with urine nicotine levels. I have not been able to do that over here. However, my routine is still the same to enroll them into a smoking cessation program and get their guarantee that they've stopped smoking. And I try my best to counsel them about the hazards of smoking. This is my routine about smoking, and I still hold fast to this rule that they have to stop smoking, and I let them understand that the risks of acute risks of leak are higher in smokers, and the long-term risks of ulcers are also higher. I do have a comment about the SASI procedure. I think there is still very scarce information about this procedure. We are still learning about this procedure. I don't think it should be done out of a IRB review protocol. I think there needs to be long-term data available. Short-term data has already indicated a high incidence of hypoalbuminemia in the paper that was published probably a year ago. And though the sample size was small, of course, there is a lot of discussion about the length that is being bypassed and that if that has contributed to the hypoalbuminemia. But in any case, what I've heard even from panelists who are doing it over here, like Maz has mentioned that he has found a few patients who had malnutrition issues. So I strongly think that there has to be a very strong protocol. There has to be a multidisciplinary team that is following these patients with a documented follow-up on how they're progressing and what problems they're facing and their nutritional parameters. Bariatric surgery is still evolving, and especially in Pakistan, where we are starting off, we should try to avoid going into gray areas where we may end up having the public swerve away from the utilization of bariatric surgery, and even get the doctors and other physicians disengaged from us, because it's important to engage our physician community. These patients, when they develop complications, they go to other physicians in the community and they badmouth bariatric surgery and bariatric surgeons. So I think we have to be a bit careful over it.
Hello. Assalamu alaikum, everybody. This is Shahzad.
Alaikum Shahzad sir.
How are you, Imran?
Thank you, sir. Thank you, sir.
Thank you. So I've been listening all the talks since morning. There were excellent talks by every panelist. I heard the talk of Dr. Javed on complications, Dr. Tahir, which is an excellent talk on the medical management as well as the weight-losing drugs. And also lately, Ma's talk on, it's a lot of been discussed regarding the SASI procedure. And also, I also heard the talk of Dr. Farooq Afzal as well. Two comments just. One is about the SASI. Has been the consensus among the Maaz and the Imran that SASI procedure probably is more of a malabsorptive procedure as compared to a restrictive procedure. So the choice of patient in which we recommend the SASI procedure is probably not of a lower BMI patient. And also when it is chosen as a primary procedure, probably will have to tailor-made the sleeve according to the SASI procedures, that is to keep it wider, as well as the antral pouch should be bigger as compared to a conventional or usually made for as far as for the sleeve. If the panelists agree with it, I would like to know their comments as well. And also a question to Dr. Tahir, if he is here. Dr. Tahir, you have an excellent talk and you have given us a good idea of the use of weight-losing drugs, particularly the GLP-1 analogs. Is there any study or your comments regarding the empirical use of this liraglutide or any other drug in the initial stages of patients who have a larger BMI and who have underwent one of the bariatric procedure, and the concomitant use of these weight-losing drugs as well, rather than waiting for or using them only for the weight recidivism or weight gains?
Should I start
Any
with
comment?
my or
Yes.
the other? Okay. So excellent question. Thank you very much, Dr. Shahzad, for the question. And sorry, I forgot to also convey my greetings to Dr. Imran and Dr. Umar. It's good to see both of you. Thank you very much. So now going back to the question, so it's quite interesting. We're still learning about GLP-1 analogs at this time. We don't have any large study. Actually, I don't know of any studies honestly where GLP-1s have been used in bariatric patients. However, in my discussion with various bariatric surgeons who are also managing medically, they have used GLP-1 in bariatric patients. Now, the effect is basically the GLP-1 effect, which is one of the effects of bariatric surgery. So bariatric surgery also increases the GLP-1 effect because of 2 or 3 different pathways. So you already have the GLP-1 effect with bariatric surgery, but that effect is primarily within the first year. So I don't actually see any utility of using this medication within the first year after any bariatric procedure. However, I have started using it post 1 year in patients who've not been able to achieve the weight loss that they were aiming for. So yes, I do use it, especially based on the indications. So if the indication is a BMI above 30 and they're wishing to have more weight loss due to certain conditions that they've got, then I do prescribe them Victoza. I gradually increase their dose and see how their effect is. I still cannot comment on the efficacy. I've only done it on 2. I will see what the results are and share it with you over time, inshallah.
I'll invite Dr. Abul Fazal.
Shahzad, sorry, just adding to that, Tahir, because in our center, because we have to put a patient through a 1-year pre-surgery program. So most of them go on to GLPs and analogs. And they follow on that one before they move on to the surgical pathway. So there is an effect there on super obese, especially super obese. I think they do tend to lose some, like 15, 20 kilograms of weight before while they've been on it for a year. But as far as Tahir said, exactly the same practice we have, that after surgery, the ones who have had either weight regain or not lost enough weight, before you subject to any second procedure, they are managed with GLPs and other medical management before they can be approved.
Thank you, sir.
And
sir, it can close anytime. We can, Professor Abul Fazal is waiting because system will turn off now. We want to have a message from Professor Abul Fazal. He's the chairman of this session. Yes, sir.
It was an excellent program and the talks were of high standard. And this panel discussion was like icing on the cake discussing all the important issues that we are facing and the new developments like this medical agents. So I congratulate Dr. Maz and I congratulate all the panelists for sparing their time and making an effort to produce this wonderful program where we learned a lot. Thank you.
Thank you, sir. So nice of you. He's traveling and I think from his car, and we are honored to have his time and be with us. Thank you, sir. So nice of you.
Mas,
My
thank
pleasure.
you very much for at least
Mas, thank
giving us
you,
a chance
Mas.
to see
Mas,
everyone
excellent.
after
Thank
a
you very
long
much,
time.
everyone.
Excellent. Thank you.
Thank you, sir. Because
It was a nice session.
Thank you,
and,
everyone. It was great listening to all of your comments. I was in a meeting, so I couldn't participate. Thank you very much.
thank you, Dr. Atif,
Great
Dr. Umar, Dr.
presentation, Dr.
Shahzad, Dr. Amir Khan, Dr. Javed Raza, Dr. Tahir. And
Thank you.
Welcome to
thank you.
Shalamar Medical and Dental College for 5th Virtual International Conference. In 5th Virtual International SMDC Conference, under the leadership of worthy Principal, Professor Zahid Bashir and Professor Khaja Muhammad Azim, Department of Surgery is offering exciting educational and training opportunities for our surgical and allied staff and students to enhance their continued learning under the banner of Shalamar Surgical Symposium. This time, we have around dozen sessions with around 55 international and national experts